People often think of childhood as a carefree and happy time, yet it can also be frightening and upsetting. In fact, children of all cultures typically have at least some emotional and behavioral problems as they encounter new people and new situations. Surveys reveal that worry is a common experience. Close to half of all children in the United States have multiple fears, particularly concerning school, health, and personal safety. Bedwetting, nightmares, temper tantrums, and restlessness are other problems that may occur during childhood. Adolescence can also be a difficult period. Physical and sexual changes, social and academic pressures, school violence, personal doubts, and temptations may cause many teenagers to feel nervous, confused, and depressed. As stated, emotional and behavioral problems are common in childhood and in adolescence. But in addition, at least 20% of all children and adolescents in the United States have a diagnosable psychological disorder. Anxiety disorders are particularly common among children and adolescents. This group of problems include adult-like disorders such as social anxiety disorder and generalized anxiety disorder. The childhood form of separation anxiety disorder, which is characterized by excessive anxiety, often panic, whenever a child is separated from a parent, and selective mutism, in which the children fail to speak in certain social situations, such as in the classroom or in the company of other children, but have no difficulty speaking at home when with family members or in other such situations. Let us go into a little bit more detail about childhood anxiety disorders. Anxiety is, to a degree, a normal part of childhood. Since children have had fewer experiences than adults, their world is often new and scary. They may be frightened by common events, such as the beginning of school, or by special upsets, such as moving to a new house or becoming seriously ill. In addition, each generation of children is confronted by new sources of anxiety. Today's children, for example, are repeatedly warned, both at home and at school, about the dangers of internet browsing and online predators, child abduction, drugs, school shootings, and terrorism. They are bombarded by violent images on the web and television. Even children's books and family movies, such as animated films, often contain frightening images that upset many children. Children may also be strongly affected by parental problems. For some children, these anxieties become long-lasting and debilitating, interfering with their daily lives and their ability to function appropriately. These children may be suffering from an anxiety disorder. Surveys indicate that between 14 and 25% of all children and adolescents experience an anxiety disorder. Some of the childhood anxiety disorders are similar to their adult counterparts. Childhood-specific phobias, for example, usually look and operate much like the phobias of adulthood, and a number of untreated childhood phobias grow into adult ones. More often, however, the anxiety disorders of childhood take on a different character from that of adult anxiety disorders. Consider generalized anxiety disorder. marked by constant worrying, and social anxiety disorder marked by fears of embarrassing oneself in front of others. In order to have such disorders, people must be able to anticipate future negative events like losing one's job, having a car accident, fainting in front of others, take the perspective of other people, and or recognize that the thoughts and beliefs of others differ from their own. These cognitive skills are commonly beyond the capacity of very young children, and so many of the more cognitive symptoms that characterize generalized anxiety disorder and social anxiety disorder in adulthood do not usually appear in earnest until children are 7 years old or older. In short, odd as it may sound, some patterns of anxiety cannot fully unfold until children are afforded the benefits of cognitive, physical, and emotional growth. What then do the anxiety disorders of children look like? Typically, they are dominated by behavioral and somatic symptoms rather than the cognitive ones. Symptoms such as clinging, sleep difficulties, avoidance, irritability, and stomach pains. They tend to center on specific, sometimes imaginary objects and events, such as monsters, ghosts, or thunderstorms, rather than broad concern about the future or one's place in the world. Similarly, the anxiety symptoms are more often than not triggered by immediate situations and surroundings rather than the thoughts about events that could happen in the future. Despite the high prevalence of children and adolescent anxiety disorders, around 2/3 of anxious children go untreated. Among the children who do receive treatment, psychodynamic, cognitive behavioral, family, and group therapy, separately or in combination, have been most effective. Each approach has had some degree of success. However, studies have found that cognitive behavioral therapy fares best. Clinicians have also used drug therapy in a number of cases of childhood anxiety disorders. Let us review depression and bipolar disorders in children. 2% of children and 8% of adolescents experience depression. Childhood depression is often characterized by such symptoms as irritability, headaches, stomach pain, and a lack of interest in toys and games. In addition, over the past 2 decades, there has also been an enormous increase in the number of children and adolescents who receive diagnoses of bipolar disorder. Such diagnoses are expected to decrease now that the DSM-5 has added a new childhood category, disruptive mood. Let us review major depressive disorder in more detail. As with anxiety disorders, very young children lack some of the cognitive skills that help produce clinical depression, thus accounting for the relatively low rate of depression among the very young. For example, in order to experience the sense of hopelessness typically found in depressed adults, children must be able to hold expectations about the future. Nevertheless, a life situation or biological predispositions are significant enough. Even very young children sometimes have severe downward turns of mood. Depression in the young may be triggered by negative life events, particularly losses, major changes, rejection, or ongoing abuse. Children depression commonly features symptoms such as irritability, headaches, and stomach aches. Clinical depression is much more common among teenagers than that of younger children. Adolescence is, under the best of circumstances, a difficult and confusing time marked by angst, hormonal, and bodily changes. Interestingly, while there is no difference between the rates of depression in boys and girls before the age of 13, girls are twice as likely as boys to be depressed by the age of 16. For decades, bipolar disorder was thought to be almost exclusively an adult disorder, and that its earliest age of onset is the late teens. However, beginning in the mid-1990s, clinical theorists did an about-face, and a rapidly growing number of them came to believe that many children display bipolar disorder. For example, one review of national diagnostic trends from 1994 through 2003 found that the number of children and adolescents diagnosed and treated for bipolar disorder in the United States increased 40% from 25 such cases. Based on a range of research findings, the task force of DSM-5 came to the same conclusion that the childhood bipolar label had been over-replified. In an attempt to rectify this, DSM-5 now includes a new category, disruptive mood dysregulation disorder, which is used to describe children with patterns of severe range. It is hoped that henceforth, children with severe anger and temper outbursts will receive this diagnosis, and that the number of childhood bipolar disorder diagnoses will decrease. It is also hoped that the inclusion of this new category in the DSM-5 will help clinicians clarify whether certain young adolescents do, in fact, suffer from the early stages of bipolar disorder. These diagnostic issues are particularly important because the rise in diagnoses of bipolar disorder has been accompanied by an increase in the number of childhood prescribed medications. Although a number of psychological approaches seem to be helpful for children with a diagnosis of bipolar disorder, fully half of those in treatment receive an antipsychotic drug. A third receive an anti-bipolar drug, and many others receive antidepressant or stimulant drugs. Yet, relatively few of these drugs or drug combinations have been tested for such use with children. Now let us move on to oppositional defiant disorder and conduct disorder. Most children break rules or misbehave on occasion. If they consistently display extreme hostility and defiance, however, they may qualify for a diagnosis of oppositional defiant disorder or conduct disorder. Those with oppositional defiant disorder, or ODD, are argumentative and defiant, angry and irritable, and in some cases vindictive. They may argue repeatedly with adults, ignore adults' rules and requests, deliberately annoy other people, and feel much anger and resentment. As many as 10% of children qualify for a diagnosis of oppositional defiant disorder. The disorder is more common in boys than in girls before puberty, but equal in both genders after puberty. Children with conduct disorder, a more severe problem, repeatedly violate the basic rights of others. They are often aggressive and may physically be cruel to people or animals, deliberately destroy other people's property, steal, or lie. They may also skip school or run away from home. Many threaten to harm their victims, committing such crimes as fire setting, shoplifting, forgery, breaking into buildings or cars, mugging, and armed robbery. As they get older, their acts of physical violence may include rape or, in rare cases, homicide. Conduct disorder usually begins between 7 and 15 years of age. Between 5 and 10% of children, 3/4 of them are boys, qualifying for this diagnosis. Children with a relatively mild conduct disorder often improve over time, but a severe case may continue into adulthood and develop into antisocial personality disorder, another psychological problem, and or a criminal lifestyle. Usually, the earlier the onset of the conduct disorder, the poorer the eventual outcome. Research indicates that more than 80% of those who develop this disorder first display a pattern of oppositional defiant disorder. More than 1/3 of children with conduct disorder also display attention deficit hyperactivity disorder, also known as ADHD. Some clinical theorists believe that there are actually several kinds of conduct disorder, including 1. The overt destructive pattern, in which individuals display openly aggressive and confrontational behaviors. 2. The overt non-destructive pattern, dominated by openly offensive and non-confrontational behaviors, such as lying. 3. The covert destructive pattern, characterized by secretive destructive behaviors, such as violating other people's property, breaking and entering, and fire setting. And 4. The covert non-destructive pattern, in which individuals secretly commit non-aggressive behaviors, such as being truant from school. It may be that the different patterns have different causes. The DSM-5 instructs clinicians to distinguish those individuals whose conduct disorder is marked by particularly callous and unemotional behaviors. A number of researchers distinguish yet another pattern of aggression found in certain cases of conduct disorder: relational aggression, in which the individual is socially isolated and primarily performs social misdeeds such as slandering others, spreading rumors, and manipulating friendships. Relational aggression is more common among girls than boys. Many children with conduct disorder are suspended from school, placed in foster homes, or incarcerated. When children between the ages of 8 and 18 break the law, the legal system often labels them juvenile delinquents. More than half of the juveniles who are arrested each year have a history of being arrested. Boys are much more involved in juvenile crime than girls. Although the gap between them is narrowing, girls are most likely to be arrested for drug use, sexual offenses, and running away. Boys are most likely to be arrested for drug use and crimes against property. Although any number is too high, it is encouraging that the number of arrests of teenagers for serious crimes have fallen by 1/3 since the turn of the century. What are the causes of conduct disorder? Many cases of conduct disorder, particularly those marked by destructive behaviors, have been linked to genetic and biological factors. A number of cases, however, have also been tied to drug abuse, poverty, traumatic events, and exposure to violent peers or community violence. In addition, conduct disorder is often related to troubled parent-child relationships, inadequate parenting style, family conflict, marital conflict, and family hostility. Children whose parents reject, leave, coerce, or abuse them, or fail to provide appropriate and consistent supervision are apparently more likely to develop conduct problems. Children often seem more prone to this disorder when their parents themselves are antisocial, display excessive anger, or have a substance use, mood, or schizophrenic disorders. As they do with regard to other psychological disorders, developmental psychopathologists explain conduct disorder by pointing to interactions between these various factors. Research shows, for example, that some, not all, children who are maltreated go on to develop conduct disorder. Why only some? According to several influential studies, maltreated individuals are especially likely to develop conduct problems if they were also born with a particular variation of a gene called the MOA gene, MAOA gene, nicknamed the human warrior gene. On the other hand, children who are similarly maltreated but who do not carry this particular gene are not nearly as likely to develop conduct disorder. How do clinicians treat conduct disorder? Because aggressive behaviors become more locked in with age, treatments for conduct disorder is generally most effective with children younger than age 13. A number of interventions, from sociocultural to child-focused, have been developed to treat children with this disorder. Clinicians have treated children with conduct disorder by using approaches such as parent management training, including parent-child interaction therapy, multi-systematic therapy, problem-solving skills training, and coping power program. Some individuals with this disorder have been institutionalized in juvenile training centers. A number of prevention programs have also been developed. Now let us review attention deficit hyperactivity disorder. Children with attention deficit hyperactivity disorder, also known as ADHD, have great difficulty attending to tasks or behave overactively and impulsively, or both. Because all children are inattentive and impulsive to a certain extent, the symptoms must be beyond what is developmentally normal in order to qualify for a diagnosis of ADHD. ADHD often appears before the child starts school. The symptoms of ADHD often feed into one another. Children who have trouble focusing attention may keep turning from task to task until they end up trying to run in several different directions at once. Children who move constantly may find it hard to attend to tasks or show good judgment. In many cases, one of these symptoms stand out as much more than the other. About half of the children with ADHD also have learning or communication problems. Many perform poorly in school, a number have difficulty interacting with other children, and about 80% misbehave, often quite seriously. The children may also have great difficulty controlling their emotions, and some have anxiety or mood problems. Around 7% of all children display ADHD at any given time. As many as 70% of them are boys. Those whose parents have had ADHD are more likely than others to develop it. The disorder usually persists throughout childhood. Many children show a lessening of symptoms as they move into mid-adolescence, but as many as 60% of them, particularly those with more severe symptoms, continue to have ADHD as adults. The symptoms of restlessness and overactivity are not always usually pronounced in adult cases. Adults with ADHD have higher than average rates of substance misuse, risky sexual behavior, driving accidents, and job changes, and they tend to earn a lower income than others. ADHD is a difficult disorder to assess properly. Ideally, the child's behavior should be observed in several environments, such as school, home, and with friends, because the symptoms of hyperactivity and inattentiveness must be present across multiple settings in order for ADHD to be diagnosed. Because children with ADHD often give poor descriptions of their symptoms, it is important to obtain reports of their symptoms from parents and teachers. And finally, although diagnostic interviews, rating scales, and psychological tests can be helpful in the assessment of ADHD, studies suggest that many children receive their diagnoses from pediatricians or family physicians rather than mental health professionals, and that at most 1/3 of such diagnoses are based on psychological or educational testing. Now let us review the causes of ADHD. Most of today's clinicians consider ADHD as a result from several interacting causes. Biological factors have been identified in many cases, with genetic studies suggesting that certain children have a predisposition to display inattention, impulsivity, and overactivity. To appreciate the brain factors that many contribute to ADHD, it is necessary to first understand normal human cognition. There are two complementary processes that make up our moment-to-moment attention. Type 1 attention processes are beyond our voluntary control and focus our attention on unexplained things that occur in our surroundings, such as sudden sounds or startling information. In contrast, Type 2 attention processes are mental activities that we control, and they involve our effortful focus and attention. In order to attend to our environment properly, we must have an appropriate interplay between type 1 and type 2 attention processes. The symptoms of poor attention that characterize ADHD are commonly understood as a breakdown in the balance between type 1 and type 2 attention processes. Brain scan studies have identified an attention circuit, a number of structures that work together throughout the brain to bring about attention and to maintain a proper balance between type 1 and type 2 attention processes. Research on the possible ties between the attention circuit and ADHD is still unfolding, but indications are that individuals with ADHD have a dysfunctional attention circuit marked by poor communication, that is, low interconnectivity between the structures in this circuit, as well as by abnormal activity of the neurotransmitter dopamine throughout the circuit. Given the dysfunctional attention circuit of these individuals, their type 2 attention processes are, more often than not, simply unable to override their type 1 attention processes. In addition to biological factors, ADHD has been linked to a high level of stress to family dysfunction. In fact, some studies suggest that these negative factors interfere with the development of effective type 2 attention processes. In addition, sociocultural theorists have noted that ADHD symptoms and a diagnosis of ADHD may themselves create interpersonal problems and produce further symptoms in the child. That is, children who are hyperactive tends to be viewed negatively by their peers and parents, have impaired peer relationships, and in turn come to view themselves negatively. How is ADHD treated? Almost 80% of children and adolescents with ADHD receive treatment. There is, however, disagreement in the field about which kind of treatment is most effective. The most commonly used approaches are drug therapy, cognitive behavioral therapy, or a combination of both. Around 2.2 million children in the United States, 3% of all school-aged children regularly take medication for ADHD. Many clinicians worry about the possibility of long-term effects on those who take these various stimulants. Extensive investigations indicate that ADHD is overdiagnosed in the United States, so many children who are receiving stimulants may in fact have been inaccurately diagnosed. In addition, a number of clinicians and parents have questioned the safety of these stimulants. During the late 1980s, several lawsuits were filed against physicians, schools, and even the American Psychiatric Association, claiming misuse of these drugs. Cognitive behavioral therapy, particularly interventions that seek to change and/or manage specific behaviors, is often used for individuals with ADHD. In many cases, parents and teachers are taught how to apply the principles of operant conditioning, systematically rewarding the children for attentiveness or self-control. They may, for example, set up a token economy program in which the children receive tokens whenever they attend and respond appropriately. Tokens that can later be exchanged for rewards of various kinds. Parents of children with ADHD may also receive parent management training in which cognitive behavioral techniques are combined with family interventions to help them deal with their children more effectively. Many children with ADHD also participate in summer treatment programs. Typically, these programs take the form of an 8-week therapeutic camp that provides systematic cognitive behavioral interventions in classroom-like formats. Research suggests that children with ADHD may improve most when they receive a combination of stimulant drug therapy and the cognitive behavioral treatments. According to research, children who receive both treatments require lower levels of medication, meaning, of course, that they are less subject to the medication.